Professor
I only wish I'm a superhero that can zoom in and give you all the answer. But I hope at least to discuss with you what superheroes may look like or what superpowers are. Okay, these are my disclosures. Precision medicine was actually highlighted in this Nature Outlook article in 2016, first issue of the year. It kind of said that in the next decade, we will be completely into precision medicine. Now, the most important thing on the cover is on the bottom left-hand corner, and you can see the word Illumina, because what it's kind of saying is that the availability of next-generation sequencing as a technology is going to transform healthcare and help us to go into precision medicine. And many of the slides during this talk rely on next-generation sequencing technology. It is very powerful and useful. It gives us some superpowers, but not all the superpowers. It's not quite the superhero that we needed, as Jack alluded to at this moment in time. As rheumatologists, we should be proud because the first clinician that has been hailed as the person who leads on precision medicine is on the right-hand side, Archibald Garrett. His research interest is genetics in rheumatic diseases, and he first made the diagnosis of alkaptoluria based on analysis of urine, showing that it is a genetically associated disease. Now, Archibald Garrett's father is on the left-hand side, Sir Alfred Baring Garrett, who actually works at King's, a hospital that I used to work at. And he was the first person who used the term rheumatoid arthritis. At that time, there were very common chronic destructive arthritis. And so Alfred Baring Garrett did an experiment. He took urine from patients with chronic destructive arthritis. He put a string in the urine, and he realized that in some patients, they have crystal deposit in the urine overnight, while there are patients who did not. And he reasoned that these conditions are caused by two different mechanisms. Of course, the patient with the crystal deposit in the urine had chronic gout, and the patient who did not have crystal deposit in the urine had rheumatoid arthritis. So this is precision medicine. It's diagnosing the right pathology based on what's causing the disease. So the tasks that we have today are slightly different. We think that we can diagnose rheumatoid arthritis with a combination of clinical criteria blood tests. What we are struggling with is that we are spoiled for choice. We have so many different treatments, they're expensive, and we are giving treatment by trial and error. Can we come up with a tool that will predict which patient will respond to which treatment? And I think this is the challenge that Jack put to us earlier today. And maybe because we are cycling medications inappropriately, it drives the development of refractory RA. And in fact, in Maya's article, she discussed that potential pitfall about using treatment by trial and error. Now, Jack has alluded to this already. We have some relative marker of predicting response to treatment. This is about Rituximab, and we know that seropositive patients tend to respond better to Rituximab. The problem is that, of course, if you are seronegative, it doesn't say that you don't respond, it's just that you don't respond as well. So it's not an absolute yes or no, but if they're seropositive, you're more likely to respond to Rituximab. And the same is true for Abatacept. So you could use it perhaps to think about, because most patients with rheumatoid arthritis we see in clinic tend to be seropositive, you can think about the opposite. What am I going to do in patients who are double negative, both rheumatoid factor negative, ACPA negative? Some rheumatologists will consider they don't have the same disease as the seropositive patient. So you may go towards the anti-cytokine therapy for this, because we know that for TNF inhibitor, for example, they have equal response independent of seropositivity status. So that's a relative thing. But I think I'm going to highlight this study that I was involved with, but was led by Constantino Pasalis in the UK. It was one of the studies when we conducted synovial biopsies in patients with rheumatoid arthritis right at the time of diagnosis, before the patient started treatment. And we biopsied a lot of people in this study, 144 patients. And as you know, synovial biopsy is an invasive procedure. You may not think that the patient would be acceptable to them to undergo such an invasive procedure. But this study proved to be quite informative to highlight the heterogeneity in rheumatoid arthritis. So the first thing we notice in this patient who right at the time of diagnosis is that the pathology in the joints are different. And in fact, it highlighted some study that has done in established RA to show that in fact, histologically, there are patients who don't have many inflammatory infiltration. There are those that have a diffuse infiltration, mainly of myeloid, that is monocytes and macrophages in the inflamed joint. And then at the bottom, pathology that is typical with lymphoid aggregates with foci that has a high percentage of T and B cells, so a very highly organized structured. And with next generation sequencing, it's possible to look at the gene expression in the whole synovium and look at every single gene that has been transcribed. And you can look at the different pathotype and show that the pattern of genes expressed in this synovium actually differ from one another, although there is significant overlap among this type. But it kind of starts to suggest that not only the presence of cells are different, but these cells are doing something slightly different in the individual patients. And in fact, with modern bioinformatics, and this is an important part of the technology too, is that when we start to have so much data, so a gene transcriptome may give you 500,000 different gene transcripts, it's not something that you can analyze with traditional method. It is the combination of that bioinformatic analysis that allow you to start to understand what the data mean. You can actually look at the gene's transcript and try to map it to genes that you expect from different cell types. On the right-hand side are showing what you would expect the signature of different cell type to understand whether the gene signature is mapping to the function of these cells. And to prove that the gene transcript have some relevance, this analysis look at, on the left-hand side, the gene transcript associated with ACPA positivity on the left, and on the right, patients who would progress to get more severe arthritis. So the vertical axis show you the statistical scoring, and because there are so many genes, the log p-score needs to be fairly high, and anything that has been adjusted to be positive are indicated in blue. On the bottom are change in the gene expression. So at the center is 0. If you move towards the right-hand side, is an increase in gene expression. If you move towards the left-hand side, is a decrease in gene expression. So what these slides are showing is that in the seropositive patient, they have a very different gene pattern of expression that is different from seronegative patients. And on the right-hand side, you can pick out genes that are associated with progression and genes that are associated with non-progression. So genes that may well be protecting the patient from more severe damage. Now, in this study, what it showed was that these genetic, and in fact, transcriptomic marker was able to add to the known clinical variable that will predict progression. So on the left-hand side are the radiographic sharp scores, and you can see yes or no, progress or not progress, and you can see that the different pattern of pathotype were associated with different rate of progression, and the lymphoid pathotype was the group that particularly tend to progress. On the right-hand side is a ROC curve showing that if you added these genes to the clinical variable, you can increase the prediction of whether patient will progress or not. So it kind of said that the genetic marker may well help us to classify patients better than the traditional clinical biomarkers. And in fact, this analysis was very intensive. On the left-hand side, you can actually take individual score, tender joint count, swollen joint count, ultrasound score, and try to map it to the activity of different cell type in the joint that you pick up the signature. And in red shows very strong correlation. In blue showed no correlation at all. And they try to infer what the roles of different cell type may well be doing in patients with rheumatoid arthritis. So this is a very, very powerful tool, and for the first time provide some validation that in fact more detailed next-generation sequencing analysis map onto the clinical features of patients with rheumatoid arthritis. And last but not least, in this study, because these patients have all just been diagnosed with rheumatoid arthritis, they were started on methotrexate, and in fact, they tried to use the transcriptomic pathotype signature and found that the signature was associated with whether the patient will respond well to methotrexate, in that the patient with the PASI immune phenotype are the group that are least likely to respond well to methotrexate. So we provide a lot of validation of this notion that we try to express in the article that I wrote together with Artie a while ago, is that even at the time of diagnosis of rheumatoid arthritis, the pathobiology within the joint is heterogeneous. And because it's heterogeneous, the type of cell presence and the kind of activities these cells are doing are really different in patients. And therefore, not surprising, we don't have a universal panacea that drive response in every single patient. So the diagnosis is the same, but the pathobiology is different. Now, recently, this technology has been applied to the microbiota, gut flora. And I'm going to show you two quick studies, because what I've just shown you is what's happening in the individual patient's joint, right? So, of course, the microbiota is in our gut, and two studies have looked at the influence of microbiota to response to treatment. Now, both studies are fairly small, 50 patients, less than 50 patients in each of this study. But it gives some idea that maybe the microbiota adds to the patient's factor in driving response to treatment. Now, in this study, patients were followed up long-term, and the patients were taking either a conventional synthetic disease-modifying drug or biologic agents, and they classified the patient into two groups in an assessment that is either 6 months or 12 months apart. And they looked at patients in blue who has improvement in disease activity versus the patient who did not have improvement in disease activity in yellow. And at the top level, what is kind of saying is that if you look at all the bacteria that is present in the gut, there is increased diversity and activity of the bacterial microflora in patients who tend to respond to treatment well versus patients who did not respond to treatment. And it used a method of artificial intelligence or machine learning called neural network. And this method of machine learning is very commonly used in oncology to drive an understanding of biomarker in the treatment of cancer. And it kind of said that, wow, this presence of bacteria is more important than some of the clinical criteria we tend to determine response to treatment. So if you look at panel C on the right-hand side, using this curve, it shows that these bacteria presence in the microflora is perhaps even more important in looking at response to treatment to this conventional synthetic DMARD and biologic molecule. On the top of this slide, on panel B, shows the positive and negative predictive value of these patients. So one of the things you have noticed is that this is a relatively small study. So on the boxes, the numbers are very small, 14, 4, 16, 12, and 0. So it kind of gives you a proof of concept principle that the microflora, that the gut microbiota may be important in clinical disease activity. Now, a study that perhaps is a little bit more homogeneous in study profiles. So these are patients who all just have rheumatoid arthritis diagnosed and just about to start off with methotrexate, conducted similar analysis. They collected fecal samples and looked at the microbiota in the feces. But in addition to look at the microbiota, they also look at the metabolic profile of the bacteria. So we also analyzed what kind of products these bacteria were producing. Now, what this study is different in the last study is that it didn't quite generate the same result in terms of bacterial diversity and the richness of the microbiota. In this study, it shows that patients who respond to methotrexate, shown in blue, actually have less diversity than patients who did not respond. But what they find was that it's not the type of bacteria that you find in the fecal sample that were associated with response, but what they produce, the metabolic response. It is the heat map produced by the metabolomic analysis of this bacteria that were associated with clinical improvement. And in fact, the metagenomic prediction, according to this study, is very strong, as shown on the right-hand side with an area under the curve of 0.8. Now, the weakness of this study is that it uses a slightly unusual definition of response to therapy. In defining response to methotrexate, it requires the individual to have a reduction of disease activity score of 1.8 at 4 months after starting methotrexate. Now, that is quite a tough bar, and not surprisingly, many individuals were classified as a non-responder. So there is some question whether, if you take it to everyday clinical practice, whether this analysis of the microbiota would help. But it did suggest one thing, that is the bacteria microflora in the gut is important, and what they are doing may well modify disease activity. There are a couple of caveats I want to, in addition, inserted into this discussion, is that the microbiota is not fixed. The microbiota is changeable. Diet can change our microbiota. Should we use the microbiota as a predictor of response to therapy? Or we should aim to change the microbiota if we know what is good and what is bad for us. And the second thing sometimes we forget is that our medication can change the microbiota. One of the commonest medication we use that change the microbiota is NSAIDs. NSAIDs have different acidity, they can cause different degree of inflammation in the bowel, and many studies have shown that NSAID changes the microbiota. And I think guess in the future study, we need to take into consideration whether some of these observations can be influenced and affected by NSAID intake. But at least in this study, it kind of say that if we use this analysis, it may be helpful in predicting and avoiding giving methotrexate to patients who don't respond to treatment, and indicated in blue, they will say that are the patients who would benefit from applying this model. But Jack alluded to this already. When we make the diagnosis of rheumatoid arthritis, we'll be starting methotrexate. Methotrexate is a pretty cheap treatment. Should we wait for this result, or we should use this result somehow to supplement what we are subsequently going to be doing? So I guess with every advancing technology, we need to see what the potential is and how we can fit best into everyday practice. But I want to go back into this issue about synovial signature, which seems to subgroup patients into different groups. And I want to highlight a study that RT was involved in a couple of years ago, when they look at synovial biopsies in patients with established rheumatoid arthritis. And again, as I said, it found these 3 different pathotypes in the joint, as shown by this slide. Now, in that study, it also took data from a study called the ADACTA study, which compared adalimumab with tocilizumab as monotherapy. And you are familiar with the result of that study. It did show that tocilizumab was superior to adalimumab as monotherapy. But in the synovial analysis, they managed to identify some potential marker, CXCL13 for tocilizumab and soluble ICAM1 for TNF. In fact, this biomarker was first looked at in the synovial tissue, and then they look at it in the blood, because they reasoned that for the majority of patients, they won't have a synovial biopsy. Could we look in the joint and find a biomarker in the blood? And they suggested that it may well be possible to use that approach to identify a predictor of response to biologic therapy. I want to highlight to you that, in fact, this is possible but challenging, because in the study that Constantino led in the early arthritis study, we did have the opportunity of looking at the peripheral blood transcriptome together with the synovial transcriptome. So the synovial transcriptome is shown on the left-hand side. The peripheral blood transcriptome is shown on the right. And one of the first things you notice is that it's much easier to pick up signal in the joint compared with the blood. You can see that there are far more colored dots on the left-hand side, which means that the fold or the difference that you find before and after treatment is so much greater. And in fact, if you look at the bottom, what you are seeing in the fold change of protein, the fold change of protein is also much bigger in the joint than in the blood. And it's quite hard to pick up genes that are expressed in the joint that have equal expression in the blood. So not easy. But if you know what happened in the joint and then look at the gene transcript on the blood, there are some potential ones, and you can focus on the right-hand side of this rather complicated slide. So the potential genes that are both increased in the synovial tissue and the blood, and they're both statistically significant, are indicated by large purple dots on this slide, on the right-hand side. So there are some, but not many. So it shows that this is no easy task. And I think actually the recent pandemic shows us why this is so. Because inflammation needs to be contained. When we have uncontrolled systemic inflammation, it kills the individual. That's why we have hyperinflammation with COVID-19, and that's why we need to use immunosuppressant to treat many of them, because uncontrolled inflammation in the blood is going to be a terrible consequence for the individual patients. Okay, so move on quickly to a couple of additional analysis. So there are some researchers who want to say, well, you know, taking whole blood is too messy. We want to refine the analysis. And in this study from the Netherlands, they separate out the peripheral blood cells into lymphocytes and then monocytes. And in addition to looking at transcriptome, they also look at what we call epigenetic control. So after genes are expressed, some of the genes are methylated. These are called epigenetic modification, and it can affect function. So in this study, in addition to doing the transcriptome, they also look at whole genome methylation. And they try to look at whether the genes and the methylation is associated with response to treatment. And they look at 80 patients who were started on either adalimumab or etanercept. And at the bottom right-hand side, you can see that methylation was much higher in patients receiving etanercept than adalimumab. And on panel C, they try to use clusters of genes that look at responder and non-responder. And in this study, the definition of responder is standard EULAR moderate or good responder. And what they kind of conclude is that they think that there are different signatures in the lymphocytes and monocytes, as well as in the hypermethylation that are associated with response, but in an individual basis, they are not good enough to predict response. So they combine the two and use machine learning to try to come up with algorithm that will predict response. And this is summarized by this slide. On the top C and D panel, it looked at the predicted response from the model on patients receiving etanercept and adalimumab. Now, for this study, one of the challenges that the result was different from adalimumab and etanercept, although both of them are TNF inhibitors. The second issue that is more difficult to understand in this study is that despite they use fairly standard response criteria, the non-respond rate was very high. The non-responder rate is about 50%. A 50% non-responder rate in a routinely TNF inhibitor treated population is probably not reflective of all our everyday experience. So this is a small study. It shows the potential of the technology, but not quite ready for big time. But we can take a slightly different approach to all this study. So this is a study that Jack has mentioned to you already. When you use a slightly different method of machine learning or artificial intelligence called decision tree, and we put all clinical variable and biomarker into a model into clinical trials and ask it to come up with a predictive algorithm of response. And I guess one of the advantage of this kind of model is that it forces some factors that we use in routine everyday practice, like CRP, like ACPA, in addition to the biomarker. In the last study, it makes no assumption. It put everything into the computer and asked the computer to come up the answer to the world. And in that setting, that algorithm may not reflect what we practice every single day. It takes the clinician and patient out of that decision picture. But it did show that it is possible from these variables to come up with certain algorithm that would predict response to Sarilumab versus adalimumab. The important limitation of this study is that this is based on clinical trial data, and we know that clinical trial data are not 100% reflective of everyday practice, and we need to validate this data set. But ultimately, I think what we need is randomized controlled trial, a proof of concept that a biomarker study would predict response. And this was conducted and published last year, again led by Constantino Pisalis. And it took TNF inhibitor failure patient, and they were randomized to tocilizumab or Rituximab as a switch of mode of action. But the patients all had synovial biopsy at the beginning, and they were classified to either have many B cells present in the joint or no B cell in the joint. And the hypothesis of this study is that in the patient who have high B cell activity in the joint, they are more likely to respond to rituximab. While the patient with no B cell in the joint, they're more likely to respond to tocilizumab. And in fact, in the B cell poor patient, this was indeed the case. If they have no B cell activity or the presence of B cell in the joint, the percentage of patients who achieve a CDAI 50% improvement was significantly higher in the tocilizumab group compared with the rituximab group. If you look at the B cell rich population, in fact, the patient responds to both treatment equally well. There is no difference between the two groups. So the R4RA is one type of biomarker stratification RCT. But I will argue that if we really want to move on to precision medicine, we need to be more clever than that. And there are more sophisticated clinical trial design, a more adaptive design that people in oncologists have used. They would able to stratify the patient, identify the different biomarker, reason which drugs the patient would respond to, start to do the clinical trial, you perform an interim analysis of this patient, and you can say that in fact the biomarker doesn't work, so you stop certain arm of the trial, or you find that the biomarker worked much better than you expected, then you enrich the population that they are responding to and try to get to a specific patient characteristic that will respond to therapy. This kind of trial design in oncology is called an umbrella trial design. But if you want to be a really pathology-based treatment, you want to move one step further, because we have many chronic immune-mediated diseases. In rheumatology, we have ankylosing spondylitis, psoriatic arthritis, and rheumatoid arthritis. We use some common biologic molecules. So what we may do is to group these different chronic inflammatory disease together, do the molecular biomarker analysis, stratify the patient, and then in a single study, assess whether the medication will map onto pathology. And that will remove the disease-specific label for particular intervention. By that time, we have arrived at precision medicine. Everything will be truly based on the biomarker of the patient. And this is the kind of stage that the oncologists have reached, but not in rheumatic diseases. So in summary, precision medicine hopes to deliver tailored treatment for individual patients. We know that synovial pathology and molecular signature are different in patients, and we do know that, in fact, environmental factor can also modify response to treatment. The availability of technology with multi-omic approach and machine learning really greatly enhance our understanding of the biology, but to apply this in everyday clinical practice is still a challenge. But at least we are starting on the pathway of doing biomarker-driven trials, but I suspect it will take us a few more years to deliver precision medicine for rheumatic diseases. Thank you very much for your attention.
Thank you very much, Dr. Choy. You raised the microbiome. You got a couple of microbiome questions here. Non-steroidals create a more or less favorable microbiota environment?
In general, for inflammatory bowel disease, it is said that non-steroidal anti-inflammatory drugs is bad for diversity. So in theory, it is bad, but we don't have data in inflammatory joint disease.
Okay. Yes.
A study by Ernest from the University of Michigan identified 4 subtypes. Lymphoid responded retrospectively to TNF inhibitors. The myeloid responded to IL-6 inhibitors. When you talk on a practical basis, and you're from England, they're doing synovial biopsies. Why can't we do a synovial biopsy, identify the cell type, and then make a decision? Thank you.
That's a great question. So there is a question that I was going to ask you. Do you think that patient will accept synovial biopsy? That was one of the reasons why the dentist study was done, because the perception is that patient won't accept synovial biopsy. More recently in Europe, synovial biopsy is more accepted. To do histology pathotype, as the R4RA study showed, was that it is kind of useful, but not as predictive as the molecular signature. And the reason is this. Doing histology is like taking a registry of students attending your lecture. It tells you whether the student is there. The molecular signature is telling you what they are doing. Are they paying you attention or not?
I think the problem is with the pathologist. The more experienced they are, the better the answers they'll give us.
Yeah, well, even as you know, for oncological diseases, the histopathology only performed to a certain extent. It's not quite good enough to stratify, but molecular signature performed well enough for the FDA to allow approval of drugs based on molecular signatures.
Yeah, and one of the other things with the biopsy is, of course, that it's heterogeneous within the synovium. So you have to make a decision. Are you going to go where the synovitis is on ultrasound, and now we're doing mostly ultrasound-guided biopsies? Or do you take multiple biopsies and then aggregate the tissue to get sort of a mean sample of that? So that's one of the philosophical issues about synovial biopsy.
Yeah.
Another microbiome question, what about probiotics in rheumatoid arthritis?
Well, I guess the first question is, would it do any harm? The answer is not likely. I had my yogurt this morning, I have to confess. But I think whether it would do any good is a different question. In inflammatory bowel disease, it's pretty clear. Probiotic help inflammatory bowel disease. So we can only take it from their literature because they study NSAID and the microbiome a lot longer than we have. We don't have as detailed data in rheumatic diseases.
Okay. Well, I think I'll ask the rest. We'll have Dr. Choy switch with me, and we'll have the panel back up and have questions for the entire panel on rheumatoid arthritis.